Hello everyone. Once again, welcome to you all to our pediatrics university question answer discussion. In the last video, we were discussed about the yes, we will start with the protein energy malnutrition. In that, we were discussed about the age independent criteria for the definition of the metaparam circumference. Then we learn about the formula for the set score, that is measured individual value minus a reference median divided by the standard deviation of reference median. Then we talked a little bit about the what are the hazards due to the undernutrition. Then etiology for the undernutrition and the pathophysiology for the of pathogenesis of the edema, and also the classification of the undernutrition, that is the WHO classification, IAP classification, GOMS classification, and like that. Then also we discussed about the clinical symptoms of the undernutrition, that is there are two clinical symptoms in under the undernutrition, that is marasmus and kwashiorkor. The wasting is the hallmark of the marasmus, and the child appears very thin, and wasting is visible in the arms, buttocks, and thighs. There is loss of buccal pad of fat give rise to old man look of the monkey facies. The child is alert but irritable, but there is no edema. And the grades of wasting, we already talked about that. Then about the kwashiorkor, the triad is growth retardation, edema, and the mental changes, that is apathy. The grades of edema, we already talked about that. Then, what are the other features of protein energy malnutrition? So, in this video, we have talked about the further details about the protein energy malnutrition. So, other features of protein energy malnutrition, which include this we have നമുക്ക് സിസ്റ്റം വൈസ് പോകുന്നതായിരിക്കും നല്ലത്. സോ അപ്പിയറൻസ്, the fat sugar baby appearance in the kwashiorkor and the old man look in the marasmus, that is fat sugar baby appearance in the kwashiorkor and the old man look in the marasmus is the appearance. And the muscle wasting with hypotonia and inability to walk. Then skin changes like a hypopigmented, hyperpigmented, and erythematous skin, and flaky pain dermatosis. That is the important one. That is flaky pain dermatosis. That is more in extremities, and the hyperpigmented patches peel off to expose raw or the hyperpigmented areas. And this is then we have the crazy pavement dermatosis. That is cracked lesions in the flexures, uh, groin, and buttocks, which is infected and ulcerated, which usually happens in the case of kwashiorkor. That is flaky pain dermatosis and the crazy pavement dermatosis. Then we have the hair changes like sparse, easily pluckable, and hypopigmented hair. There will be flag sign, that is during recovery, the root of hair is pigmented and the tip is hyperpigmented. And the curling and change the texture of hair will be absent. These are the hair changes in the protein energy malnutrition. And the mucous membrane, we have glossitis, chelosis, and angular stomatitis. And due to the fatty infiltration of the liver, patients have the hepatomegaly. And the apathy is more commonly the kwashiorkor, and irritability is most commonly the case of marasmus child. And the loss of interest in the surroundings is called the apathy. And the regression of social smell, these are the mental changes which is usually happens in the case of protein energy malnutrition. Then we have the GIT. There will be loss of appetite, vomiting, and abdominal distension. The abdominal distension is more commonly a feature of the kwashiorkor. Then we have the cardiovascular system, that is microcardia, cardiomegaly, and tachycardia will be the. Then anemia, bleeding, and purpura as the hematological changes in the protein energy malnutrition child. So these are the other features of protein energy malnutrition. Then in the marasmus kwashiorkor, there is development of the edema in the marasmic children. Only in the marasmus kwashiorkor, there is development of the edema. Then underweight child is malnourished but has no features of the marasmus or the kwashiorkor, that is underweight. Then weight is 60 to 80% expected. Then this is a major or the important topic, that is difference between the marasmus and kwashiorkor. That is a commonly asked university question. The difference between marasmus and kwashiorkor. In the marasmus, the majorly it is a caloric deficit syndrome, but in the kwashiorkor, that is all. It is mainly due to the protein deficiency with a relatively less caloric deficit. So marasmus is a caloric deficit, but the kwashiorkor is a protein deficiency with relatively less caloric deficit. Then age, it is usually marasmus, which is usually occurs at the age of 0 to 3 years, but the kwashiorkor, which is usually occurs at the age of 1 to 3 years of age. Then the marasmus, the term which means wasting. So the child is looks like everything is wasted. Then kwashiorkor, which means the red baby. Then about the response, there will be in the marasmus, there will be adaptive response, but in the kwashiorkors, there will be maladaptive response. Because of that, there will be edema. And so the edema is not present in the case of marasmus, but the edema is included in the triad of the kwashiorkors. It is usually in the lower limb. Then wasting, all the skin and bones are wasted, and it looks like a thin old man. And in the kwashiorkors, there will be wasting is hidden. That is due to the edema. Because of the presence of the edema due to the maladaptive response, there will be the wasting is hidden. Then in the growth retardation, the most common one of the major features in the triad of the kwashiorkor is the growth retardation. But kwashiorkor, the growth retardation is hidden, but in the marasmus, the growth retardation is obvious. And the deficiency, the weight and height is very much weight is very much decreased, but the height is that not much decreased increased. The weight is there will be but in the kwashiorkor the height is very much deficiency, and the weight that is not that much. And the mental changes, in the kwashiorkor, the patient is apathetic. This is a difference. That is, in the kwashiorkor, this is not the right. In the kwashiorkor, the child is apathic. Then in the marasmic child, that is very irritable. And the skin changes that may be present, but in the kwashiorkor, there may be evidence of the flaky paint appearance. In the appetite, the marasmic child is very hungry, but the kwashiorkor, there will be poor appetite. So lack of the appetite and apathy is a major characteristics of the kwashiorkor. Then the hair, in the kwashiorkor, there is sparse, deep, pigmented, straight, and lusterless hair is present. That is, flaxen is also present. And the investigations, we have to look for the albumin, hemoglobin, and liver biopsy. The albumin is decreased in the case of kwashiorkor. That is because of there will be presence of edema. Likewise, we have to remember that albumin is decreased in the case of the kwashiorkor, so that will produce the edema. Then hemoglobin, it is decreased in the case of marasmus. It is much decreased in the case of kwashiorkor. And if we take a liver biopsy, there will be normal in the case, that will be normal in the case of marasmic child, but it is kwashiorkor, there will be fatty changes in the liver biopsy. So these are the major difference between the marasmus and kwashiorkor. That is, deficit is due calorie. There is calorie deficit in the case of marasmus, but the protein deficiency with relatively less calorie deficit in the case of kwashiorkor. Age is 0 to 3 years, and it is 1 to 3 years in kwashiorkor term. The marasmus, which means wasting. So the child looks like old man, and the kwashiorkor, it means red baby, red body. And then we have the features like response. There will be adaptive response in case of marasmus. There will be non-adaptive, maladaptive response in case of kwashiorkor. So there will be production of the edema on the lower limbs. Then we have the wasting all the skin and bones. Therefore, it looks like thin Altman. And the wasting is hidden due to the edema in the case of kwashiorkor. And the growth of tradition is obvious in case of marasmus. And the mental changes apathetic is kwashiorkor. It is not right. Kwashiorkor have the patient have the apathy, that is does not interested in the surroundings. The skin changes which may be evident in the kwashiorkor, like flaky paint appearance, and then craved pigment appearance also. Then appetite is poor in the case of kwashiorkor. So therefore, poor appetite and the apathy is a characteristic piece of the kwashiorkor. Then we have the hair, lusterless hair, flaxing. Then investigation, albumin is decreased in the case of kwashiorkor. Hemoglobin is much decreased, and the liver biopsy show fatty change in the case of kwashiorkor. So these are the major difference between the marasmus and kwashiorkor. Then some little bit about the moderate acute malnutrition. When the set score of the weight for height is less than minus 2 standard deviation, it is called the moderate acute malnutrition. Such children which can be managed at the home, does not need to be admitted in the hospital. Such children which can be managed at home, and with timely intervention, the severe acute malnutrition which can be prevented. This is the moderate acute malnutrition versus some table. In the severe acute malnutrition, there will be presence of edema is there, and the weight for height is less than 70%. So the set score value is less than minus 3 standard deviation. But in the case of moderate, it is -2 standard deviation. And the mid-upper circumference is less than 11.5 centimeter in the case of the severe acute malnutrition. But in the case of moderate acute malnutrition, it is 11.5 to 13.5 centimeters. So these are the criteria for the diagnosis of severe acute malnutrition, edema present, and the set score is less than -3 standard deviation, and the mid-upper circumference is less than 11.5 centimeter. Then what are the management of the management of the moderate acute malnutrition? It is said that such children which can be managed at home and with timely intervention, severe acute malnutrition which can be prevented. The management of the moderate acute malnutrition, which include we have to provide adequate calories, that is 150 kilocalorie per kilogram per day, and we have to also supply the protein, that is 3 gram per kilogram per day, and the frequent feeding, that is 6 to 7 times per day is required, that is adequate calorie 150 kilocalorie per day and adequate protein 3 gram per kilogram per day, and also frequent feeding 6 to 7 times per day is required. The nutrient rich and energy dense home food is recommended. The nutrient value of the food can be enhanced by the addition of the oil or ghee, amylase rich foods, sprouting and malting, that is overnight soaking of the pulses. Then we have to supply the milk and eggs, which are good animal sources, while legumes and cereals are good plant sources. And adequate vitamins and minerals should be provided for the proper duration. So these are the management of the moderate acute malnutrition. We have to provide adequate calorie 150 kilocalorie per kilogram per day, and the protein 3 gram per kilogram per day. Then the frequent feeding is required 6 to 7 times per day. Nutrient rich and energy dense home food is recommended. Nutrient values can be enhanced by the adding the oils or ghee, so the amylase rich food or the sprouting and malting, and the milk and eggs and added, and legumes and cereals, which are the good plant sources for the nutritive value. Then adequate vitamins and minerals should be provided for the proper duration. So these are the management of the moderate acute malnutrition. Then we have to go into the severe acute malnutrition and its management. So, severe acute malnutrition, as the name indicates, is a severe, silent, life-threatening emergency. The severe acute malnutrition is a major killer of young children, with the mortality rates in preschool children being 9 times higher than the general population. Incidence, it is globally 2 to 6% of preschool age children is affected because of severe acute malnutrition. In India, there will be incidence of 6.8%. India is the home to half of the total of the severe acute malnutrition. And so, what is the definition of the severe acute malnutrition? This is important. It is usually asked as a short note, that is definition and the clinical features and the management of the severe acute malnutrition. Definition WHO, between it is usually happens between the 6 months and 60 months with the, that is a criteria, that is the WHO criteria, that is the severe acute malnutrition usually occurs between 6 months and 60 months with uh, these four criteria should be satisfied, that is weight for height, that is set score is less than 3 standard deviation, less than -3 standard deviation, the median WHO standard. Then there will be severe visible wasting will be the, then bipedal edema, and the mid upper circumference less than 11.5 centimeter. So these are the WHO criteria for the criteria which is satisfied the severe acute malnutrition, that is usually happens at the age of the 6 to 60 months of age. Then weight for height is less than -3 standard deviation, then severe visible wasting, bipedal edema, and mid-upper circumference less than 11.5 centimeter. And according to IAP classification, it is again class these are the satisfying features, like weight for height is less than 70 percentage or the less than 3 standard deviation of the uh, mean. Then severe wasting will be present, and plus or minus bipedal edema. Recently, infants less than 6 months have been included wherein the WHO definition A or B or C only. Mid-upper circumference is not available for the less than 6 months. The causes of the severe acute malnutrition the less than 6 months is the suboptimal breastfeeding practices, persistent diarrhea, and low birth weight. So these are the causes for the less than 6 months severe acute malnutrition, that is suboptimal breastfeeding practices, persistent diarrhea, and the low birth weight. So these are the definition for the WHO definition and the IAP definition for the severe acute malnutrition. In the IAP, there will not be any presence of the mid-upper circumference. It is not included here. And also there will be addition of the 6 months also the this IAP. But in the WHO, 6 months to 60 months with the weight for age, severe visible wasting, bipedal element, metaperum circumference less than 11.5 centimeter. And then the major topic is the management of the severe acute malnutrition. All the children with the severe acute malnutrition should be thoroughly assessed and then should be categorized for the management as home-based, hospital-based, partially hospital-based, rehab at home with the F100 and ready to utilize therapeutic food. So these are the management options. So we have to thoroughly assess the same child and then should be categorized for the management as the home-based, hospital-based, and partial hospital-based rehab at home with the F100 and RUTF. Then appetite test. So this is the approach towards the severe acute malnutrition. The severe acute malnutrition, which means weight for height is less than minus the standard deviation WHO, or bipedal edema of the metaplum circumference less than 11.5 centimeter. And then we have to assess the child, that is fail if there is any failed appetite test, that is if there is any anorexia and the fever is greater than 39 degrees Celsius or hypothermia less than 35 degrees Celsius, and if there is any persistent vomiting, if there is any severe dehydration or severe pneumonia, if there is any severe anemia or extensive superficial infection, if all these are present, any of this is present, it is known as the complicated severe acute malnutrition, and it has to be managed at hospital. So hospitalization is required. But if all this is failed appetite test, fever or there is no fever or the hypothermia or not persistent vomiting or severe dehydration or severe pneumonia, or there is no severe anemia or extensive superficial infection, and all these are absent, it is termed as the uncomplicated severe acute malnutrition, and it has to be supervised home, and it has to be undergone supervised home management. Need not be there is no need for the hospitalization. So the uncomplicated severe acute malnutrition, there will be supervised home management, and but the complicated severe acute malnutrition, we have to hospitalize the patient. What determines this complicated or uncomplicated? These are the tests, that is failed appetite test, fever of the hypothermia, persistent vomiting, and severe dehydration of the severe pneumonia, severe anemia, and extensive superficial infection. These are the these determines the complicated sum. Then what is an appetite test? It can be asked as a short note. What is the appetite test? To differentiate between the uncomplicated and the complicated SAM, and to define whether child which requires admission or the OPD treatment. The child is given fixed amount of the food. So the procedure is the child is given a fixed amount of the food. Example, ready to utilize therapeutic food, and it is checked whether child can finish the feed or not. What are the criteria for the passing appetite test? Test which can be performed using the ready to use therapeutic food or with the locally available therapeutic food. It is done on the presentation in a child with the suspected severe acute malnutrition, and also on the follow-up if there is no weight gain. In the patient with the past appetite test but poor weight gain will be there. A home visit is warranted as it may suggest a good appetite but shared medical nutrition therapy at home or some social problem. So if the body weight is less than 4, we have to give the minimum amount of the RUTF as 50 ml or gram. Then we have, in the case, if the weight is 4 to 6.9, we have to give 25. And if the weight is 7 to 9.8, we have to give 35. If the weight is 10 to 14.9, we have to give 50. So these are the quantity of the food which are used for the appetite test. Then how to perform the appetite test? A separate quiet area is required. Mother or the caregiver should wash the hands, and mother sits comfortably with the child in her lap and offers therapeutic food. Child should not have eaten anything in the last 2 hours. Child which must not be forced to eat the food. The amount eaten by the child is then measured. So that is the all about the appetite test. Then what is ready to use therapeutic food? That is RUTF. That is also asked as a short note. That is ready to use therapeutic food is an energy dense mineral and vitamin enriched. That is energy dense mineral and vitamin enriched food that has shown good results in the management of the severe acute malnutrition in both home and hospital settings. The ready-to-use therapeutic food is made up of peanut paste, sugar, milk, that is peanut paste, sugar, milk, solids, and vegetable oil with added vitamins and minerals. So it contains peanut paste, the sugar, milk, solids, vegetables oil with the added vitamins and minerals. It has pasty consistency and is easy to digest and well liked by the children. It is commercially available. Ayurvedic has which has the following compositions like peanut paste constitute 30% peanut paste, and its energy value is 543 kilocalorie, and the sugar 29 percentage, protein content is 50 gram, and also which have the milk solids 20%, vegetable oils 80%, added mineral mix, vitamin mix, emulsifier, and antioxidant. And these are the food value per 100 gram. There is energy of this RUTF is 543 kilocalorie, protein is 50 gram, lipids is 35 gram, and carbohydrate is 43 gram. And the similar mixture, that is ready to use therapeutic food, which can be also prepared locally. This is called as local therapeutic food. Uh, the composition of local therapeutic food is the roasted groundnuts, 1,000 gram. We have to take milk powder 1,200 gram. We have to take sugar 1,120 gram, and coconut oil 600 gram. And the method of preparation is take roasted groundnut and grind to them. The grind sugar separately with roasted groundnut. Mix groundnut, sugar, oil, and milk powder. Store them in the tight container in the refrigerator. Prepare only for the 1 week. Then that is the complicated SAM, which we have to hospitalize the patient. So this is the hospital management of the complicated SAM, that is assessment of the severely malnourished children. First of all, we have to assess the severely severe acute malnourished child thoroughly. That is by the history taking. We have to ask about the history of the intake of the food or the fluid recently, and the what is ask about the usual diet of the child, and ask about the breastfeeding, then if there is any diarrhea or vomiting, and ask about the appetite of the child and the family background, cough, and if there is any presence of cough, measles, and HIV in the recently or the past, we have to ask for it, then immunization. So these are the part in the case of history. We have to take a thorough history regarding this. That is intake of the food recently, usual type, breastfeeding, diarrhea or vomiting, appetite, family background, if there is any presence of cough, measles, and HIV, and immunization. And then we have to examine the patient. That is, we have to measure for the anthropometric parameters. Then we have to look for the edema, then pulse and respiratory rate, signs of dehydration. Look for any features of shock, that is cool and clammy extremities, and the severe palmar pallor, eye signs of vitamin deficiency. Localizing signs of infections like the ear, throat, skin, and lungs should be looked for, and fever or hypothermia, mouth ulcers, skin changes like a pigmentation, discoloration, ulceration, oxidative lesion. These all should be examined. And what are the investigation we should done? That is, we have to go for the complete blood count, then serum electrolytes, blood glucose. For infection, we have to go for blood um, culture and sensitivity, urine routine and culture and sensitivity, Mantox test, X-ray of the chest, and HIV. So, organization of the care, it is separated from the infected children and kept in the warm area. Facilities and sufficient staff should be available for the preparation of feeds and day and night feeding. Accurate weighing machines needed. These are the 10 steps in the severe acute malnutrition management. These are also an important short notes. That is 10 essential steps in the management of the severe acute malnutrition. So these 10 steps, which are divided into three phases, that is stabilization phase, recovery of the transition phase, and rehabilitation phase. The stabilization phase, recovery of the transition phase, and rehabilitation phase. The stabilization phase lasts for the 1 to 2 days, and the transition phase, which lasts for the day 3 to 7, and the rehabilitation phase lasts for the 2 to 26 weeks. So, 1 to 2 days stabilization phase, 3 to 7 days is transition phase, rehabilitation phase is 2 to 26 weeks. So these are the 10 steps. That is, first we have to treat the hypoglycemia, then we have to treat the hypothermia, then we have to treat the dehydration, then we have to treat the electrolyte imbalance, then we have to treat the infection, Then we have to treat the micronutrient deficiency, initiate feeding. The eighth step is catch-up growth, and ninth step is sensory stimulation. 10th step is prepare for the discharge and follow-up. So these are the 10 steps. There is treat the hypoglycemia, hypothermia, dehydration, electrolytes imbalance, treat the infections and the micronutrient supplementation, then cautious feeding, then catch-up growth, sensory stimulation, and prepare for the follow-up. So these are the 10 steps in the management of the severe acute malnourished child at the hospital. Rest of the portions, that is details about this management is discussed in the next video. Okay.